Okay, so I think I appropriately renamed what I was planning on saying from a virtual tour to a virtual tour of all the pituitary hormones. So obviously people have different backgrounds, and make sure you're muted, please. And then, so we're going to go over each gland separately, and there'll definitely be time for questions. So what we will cover, we'll cover each of the glands that are controlled by the master gland, the pituitary, and its boss, the hypothalamus. We're going to go over the symptoms of deficiency of each of the glands. I'm going to mention how to test each of the gland and how do you evaluate the medications levels and things like that. And I'm going to give you a few pituitary vocabulary words because I think they probably come up a lot and it's probably good for you to know. Okay, I hear sound in the background, so could everyone mute themselves? I hear music. Okay, I think I'm going to stop for a second. Amanda, is there a way you can mute whoever's not muted? Okay, that's better. Thank you. Okay. So meet the pituitary. So normally I would want to do this interactively. So I want you to think to yourselves for a couple of seconds, what pituitary hormones or what glands the pituitary controls. So if you're going to think of, how many can you think of? So if you want to unmute yourself and just shout out a gland, that's fine too. Why don't you do that? See?
Adrenal.
Adrenal. Survey says number 2 answer. Someone else?
Thyroid.
Thyroid by TSH. Survey says number 1 answer. Next.
Pituitary.
The pituitary, I'm asking what the pituitary controls.
Oh, sorry.
Okay.
Growth hormone?
Growth hormone, yes.
Ovaries.
Okay, so the LH and FSH, which in turn control the ovaries or the testicles, yeah.
Prolactin.
Prolactin, a direct secretion important for breast milk production, yep.
ADH.
Okay, yes, antidiuretic hormone, ADH, also called vasopressin, yep. You sort of got all the big ones. Any little ones? Then there's oxytocin, which we don't always talk a lot about. Okay, so now I'm going to move on here. So let's see what I wrote here if we covered everything. So the pituitary controls the thyroid. It controls growth hormone directly by releasing growth hormone. Almost all the other ones are indirectly by causing something else to make something. The adrenal gland, but it does not control what the adrenal is named for, which is adrenaline. So all the kids who have pituitary issue or adults, they make normal adrenaline for what it's worth. Okay, the onset of puberty and sex hormones. We'll talk a lot about that as well. It doesn't control the kidney except for the part that concentrates the urine. So someone with a kidney problem directly, they have all sorts of problems, but which our kids don't have. Breast milk production, only important in pregnancy. Oxytocin, we're still learning a lot about. And by the way, there might be other pituitary hormones we just don't know about. These are all the ones that are known. So translating that into terms, the pituitary controls the thyroid for just adequately named thyroid stimulating hormone. So TSH is not made by the thyroid, but by the pituitary. That confuses a lot of our patients who come in with direct thyroid problems and don't have a pituitary problem. They don't understand the relationship between TSH and the thyroid. Growth hormone directly, ACTH, adrenocorticotropic hormone, that's adrenal, basically stimulating hormone. Can you go on mute again, please? I'll wait for everyone to go on mute because I hear other things. Okay, thanks. Then we have LH and FSH, which are the 2 hormones which will stimulate both the testicles and the ovaries. I'm giving you, by the way, almost the whole talk on this slide, and then we're going to do it slowly. ADH, like someone said, also called vasopressin. Notice that in the word vasopressin, vaso is vessels and presso is presses them. So it also squeezes down on blood vessels. And then we have prolactin and oxytocin. So now we're going to go into each gland separately. So the role of the TSH is to tell the thyroid how much to do. So everyone has a thyroid gland in this pituitary conference. I have many patients who are born without a thyroid gland, completely different. That the TSH, the thyroid has no idea how much thyroid hormone to make. The thyroid is just a factor in the neck. It only does it in response to the pituitary making TSH. So if the pituitary is not working, then the thyroid, which is perfectly normal in all our kids, will not make its thyroid hormone. So that's the physiology of that. So what are the symptoms of hypothyroidism? So now you could unmute and give me any symptoms you think might represent hypothyroidism.
Lethargy.
So lethargy would be the number one thing. So fatigue, and obviously fatigue is difficult to tease out because there's so many reasons that our kids could be fatigued. Even just in 2020, every kid is reporting fatigue just about, even without pituitary problems. Other symptoms of underactive thyroid?
Hair loss.
Hair loss, not quite as much, but if the thyroid is really off, the hair can get very brittle and dry, and so they may start to lose some hair. It's not one of the direct, I would say, most common effects, but it is certainly possible.
Weight gain and sleep disturbances.
Okay, so we'll keep those two separately. So weight gain, and someone with a thyroid problem directly is not someone that will present with, let's say, on the subway and you say, oh my God, that person is 600 pounds. It'd be as if you saw me 5 months from now and said, wow, I think that doctor, he looks different. I think he gained a lot of weight, like 30 pounds. So it's that kind of weight gain. But it certainly lowers your metabolism when you're hypothyroid. And so you get dry skin, you get constipation, you may need a lot of naps and things like that. Okay, so I'm going to then click my slide now. So let's see all the things we talked about. So slow growth. So clearly thyroid is crucial for growing. If you're an adult with pituitary problem or thyroid problem, that's of course not an issue. You're not going to shrink. But our kids, sometimes we see kids who present with a primary thyroid problem, meaning not a pituitary gland problem, and they just stop growing for the last year and a half. So what do you think the TSH level is on those kids that have a gland problem and not a pituitary problem? What do you think? So someone with a
Very
thyroid
high.
gland, it'd be extremely high. So a normal level might be up to 4.5 or so for TSH, but the pituitary, which is functioning normally in these kids with a thyroid gland problem, you see 50, 100. The highest I've seen was 2,400. That was pretty unbelievable. I walked in the room, there was a 10-year-old boy who just looked like this. He just didn't move at all. He was so hypothyroid. He had every one of these symptoms, including some hair loss. And feeling cold, of course. So now we're going to shift from the thyroid to growth hormone. I guess it does work okay if you ask me questions during it. So I'll change my structure. If you want to ask me something before I move on, I'm totally happy to pause and go over it. I only have about 25 slides, so it's not like it's going to take me 2 hours to do this.
May I ask, can hypothyroid affect your pulse rate?
Yes, absolutely. So let's start with kids who present with an overactive thyroid, which for you would only mean if your dose was too high of the replacement. And clearly very fast rate is part of it. And you might find this interesting that kids who present with an overactive thyroid, again, not a pituitary problem, but overactive thyroid directly, 15% of them have seen cardiology first. So it's all the time. I get maybe about every 6 months, a cardiologist says to me, you know, we have this girl, most of the time this girl, that we did a Holter workup, like a 24-hour EKG, because her heart rate was so hard and she was complaining of pounding of the heart. And then we discovered everything was normal except for the fast heart rate. But then we checked the thyroid, and oh my God, the thyroid is so hyperthyroid. And usually when we see those kids, their neck is just standing out so far. And we always wonder how cardiology could have missed that, because it's the biggest goiter ever. So yes, thyroid is very important on the pulse. And kids with that 10-year-old boy I mentioned, I don't remember the number, but his pulse was like 40. So
Right. So
clearly,
if someone experiences bradycardia, would it be from the thyroid?
well, like anything else, that would be a strong consideration. And so if I had a child who had, when I say child, yeah, it could be young adult. So we'll just say child will mean pituitary patient. If I have a child that's running low heart rates, I have to consider, is this normal for them? Or is this a change? Maybe I'll flick back at a few visits ago and see if the pulse was in the 60s and 70s then, and now it's in the 50s, which is different. Is there another medication in play? Stuff like that. But yeah, I have to consider the thyroid. And if I was borderline on increasing the dose, then I might increase the dose because of that reason. It's a consideration. Anything else about the thyroid?
I do have a question.
Okay, I think it's Erin.
Okay, yeah, thank you. Sorry to interrupt. I do have a question about the T3 levels, because my son is hypothyroid and we're in Canada. So
Yes.
as far as like reference ranges go, I know that the American and the Canadian reference ranges are different. So I was wondering if you'd be able to speak to that, just so that when I go to talk to my doctors about T3 replacement, which so far they are absolutely dead against, that I have like a bit more guidance for them.
Yeah, so that, and I know that a question was asked to Christian Roth yesterday, because I was, believe it or not, I was in the background listening to most of the talks. So when in medical school, you learn that the thyroid makes two hormones, T4 and T3, and T4 means a amino acid that has 4 iodines attached to it, and T3 has 3 iodines. But the T3 doesn't come, it comes from the thyroid typically making T4 first, and so you would think it's kind of backwards. They add 4 iodines and then they cut one off. And the reason that's the case is because the body has a second way of adjusting the thyroid levels by, if let's say you were sick today and your body said, I don't want you, Erin, to be so metabolically active today. This is a kind of a rest day. Then your own body, through complex mechanisms, will shift some of your T4 levels into an inactive form of T3 called reverse T3. So it's like a second way to adjust things. The T3 is, the levels are about 1/10 of what the T4, they're clearly lower than the T4 levels. If you look at the units, you'll see they're actually quite different. And so the question is that, but T3 is very potent. So the question comes up a lot, why shouldn't we replace T3? That, as Kristen Roth said, well, the body naturally knows how to make its T3. So that's one thing.
Do our kids' bodies naturally know how to make T3?
Yes, absolutely. Absolutely. Yeah. Okay. And then if you give T3, and there are a few rare preparations that have T3 in it, T3 is a very short half-life. So reminder the term half-life, which is that how long it stays in the body, essentially. And the scientific definition is if you give someone, let's say a drug, like T3, how long is it in the blood until it gets to half its level? And with T3, it's only a few hours. For T4, it's over a day. So it's a very long half-life for T4. So we will sometimes use T3 in thyroid gland cases where they're like ready for getting this. I almost don't want to go into it, where you use the fact that it'll get out of the system soon. If someone's going to get radioactive iodine to treat a condition, either a thyroid cancer or Graves' disease, hyperthyroidism, we will sometimes use T3 because you can't get radioactive iodine when you're already getting T3, because then the radioactive iodine won't go to the thyroid, you'll just pee it out. Anyhow, that's a little more advanced. But if you ask me, is there a benefit of replacing T4 and T3? The answer is that we don't know that there is. Now, I can understand as a parent or as a scientist saying, well, what studies, have we done studies where you give someone, one patient T4 and the other one T4 and the obnoxious T3, because it has to be done a few times a day, and see if there's any metabolic parameters that are improved. And whatever studies have been done, they have not convinced our world yet that T3 should be given. And is there a situation where I would do it? Well, I do it sometime when the parents really insist. And I say, let's do it. But if you're not noticing any improvement in lethargy, things like that, let's not continue for too long. And so in terms of talking to your practitioners, I guess the scenario might come up that that if my child's been really tired and the thyroid levels, the T4 levels that you measured, you say are excellent. And I could see on the range, they're near the top, they're really good. Yet he or she is still really tired. So I'm giving the adrenal hormone, and it's not a school issue. I mean, it could be social isolation issue. I don't know. There could be other psychological issues. I don't know. But how do you feel? I've read a lot about this. I've heard about this. A short-term trial of adding T3 to the regimen. And they may go for it. They may say, that it makes it a lot more confusing for me, the doctor, to monitor the thyroid hormone levels, because it's not like we have great normals for T3 in Canada or the United States. I mentioned before that if you don't feel so well today, your body shifts from T3, instead of T4 going to the T3 you're talking about, it goes to this modified T3 that's inactive. So your body is purposely changing the amounts of T3. It's on purpose. So as a doctor, I can't just look at a level and say, okay, your level today is supposed to be here, because your body says, no, I know better. It's supposed to be very low today. I'm not feeling that great. So it's really not easy to monitor. It's not clear or show benefit. But if you want to say, if you're really having trouble with fatigue, a consideration is saying to the doctor, can we just do a short-term trial? I know it may not work, and I don't think it's a harmful thing to try. But if it's not doing anything, I would just stop. That's something you could do when you approach your doctor.
Right. Thank you. Yeah, I have done that, and they're saying no, which is fine at this time. I'll keep approaching it. But just to clarify, do you feel that there are any negative effects of trialing a T3 replacement? Because his levels are on the low side for T4 and T3. Yeah.
And we don't usually actually measure T3 in our patients, so we don't usually get into that trouble of saying they're low, but somehow it was measured. Again, because if I measured your T3 today, well, first of all, if I measured your thyroid test today, and I assume you're not the one with the pituitary issue, correct? Okay.
No, it's yeah.
Okay, so even if you were, I was going to say, maybe believe you're not. And you told me that I'm concerned about my thyroid. I would check that if I'm only allowed to get one test, what would I get? Do you know? Which test would I order? Anyone?
The THS.
The TSH? Correct.
Yeah.
The thyroid stimulating hormone, which is pretty useless in all our patients in this conference because the pituitary doesn't know what it's doing or can't do it. But for our patients with a gland problem, I really almost only need to see TSH. And if that's high, I have to go up on the dose. For our pituitary patients, it's not so helpful. Like I measure sometimes, but it says undetectable. So I don't know, it's not obviously high. So I have to rely on the T4 levels and stuff like that. And rarely do I get T3 because I don't know if it's low because the body's purposely shifting it to that reverse T3 or because it's just low. It's hard to interpret. Okay,
Thank you.
So let's move on to growth hormone. Okay, so this is directly released by the pituitary, and some of its effects, some people say 80% of its effects are not directly by growth hormone hitting the bones, by causing the liver, which is totally fine in all our patients, to make IGF-1, insulin-like growth factor 1, formerly called somatomedin C. This IGF-1 is also our diagnostic test. So, and we'll talk about testing in a few moments, so we don't have to get into that yet. Growth hormone obviously increases growth, but it also builds up muscle and decreases fat. It's not a great weight loss drug. So if we have patients with hypothalamic obesity or just high weight because 80% of the planet has high weight now, then and I just made up that number, so don't write that down, that it seems like everyone has high weight. So giving growth hormone will not cause someone to lose 10, 15 pounds, but it does definitely increase musculature. It's well known. It also maintains blood glucose. So if anyone here has a child that was presented with a pituitary problem, let's say under 6, does anyone here in the group have someone that's, okay, how old? Okay, 2 people. So 5, oh, that's good. You show me with your hands. How's your child's diagnosis? Not right now, but okay.
My child was 5 at diagnosis.
Did you ask me how she was at diagnosis or how old she was?
Yeah, hold on one second. I gotta get, thank you. Someone repairing something. I was saying at diagnosis with a pituitary problem, how old they were, or even at presentation. It doesn't have to be a diagnosis because it took us 2 years to make the diagnosis.
Exactly.
Okay, so how old would you say, Paula? 2.
But
Okay.
not diagnosed till 5.
Yeah, so 2. I'm gonna say the answer is 2 for here. And who else is it? Erin? Is that
5 years old.
5 years old? Okay. And boy or girl?
Boy.
Mine's a girl.
Okay. So for a boy that we sometimes see pituitary problems in the newborn period, meaning they developed in utero. Sometimes they might come to a meeting like this because here the title of the conference is what? Pituitary brain tumor. So it doesn't say someone, it almost should say pituitary brain tumor or someone with a significant pituitary dysfunction, because if we have a baby born with a pituitary problem, they present classically, if you're taking the general pediatric examination, you should know that one of the questions might be a newborn boy who presents with a very small penis, micro penis, and low blood sugars has a pituitary problem until proven otherwise. For girls, they'll also have a low blood sugar, but you won't see a small clitoris or anything. That won't be noticeable. You'll see nothing. So that's an important clue for us for a pituitary problem. Now, if you already, and the reason for that is because in utero, that there's effects of our pituitary hormones. So when we get to puberty hormones, I'll mention that again. So it's because of in utero effects. But if you develop, let's say, a tumor at age 2 or age 5 or 12, you've already gone through in utero making normal pituitary problems. So that wasn't an issue. But in the young kids, this last one, blood sugar is raised with growth hormone. And it's kind of interesting. I'll ask you guys this as a puzzler. If you guys were starving and not eating for a while and vomiting and your blood sugar goes from normal to a little bit low, what does your body do to bring up the blood sugar?
It goes into the fat stores?
Okay, so fat gets broken down, and then one's brain could use some of that for energy. Like half of its calories can come from that, so that's good. Okay, what about hormonally? What does it do, your body?
Produces insulin?
It actually stops the production of insulin.
Stops. Yeah.
So you remember someone with diabetes, sugar diabetes, diabetes mellitus, has a very high sugar, and they don't make insulin. So they need insulin to lower the sugar. So if your sugar is dropping low, the body shuts off insulin production. So that's one thing it does. It stops insulin. What else does it do? It actually raises growth hormone. So not to grow, because growth hormone will stimulate blood sugar production. It also, the adrenal makes more glucocorticoids, hydrocortisone, glucose, corticoids. So the body does some hormonal things, stops insulin and raises some of these pituitary hormones, very interestingly. But if you have a 12-year-old with a pituitary problem, they don't usually have low blood sugars from it. But if you have someone under 6, they definitely might. That was that long discussion to give you the story about blood sugar and growth hormone.
My daughter's blood sugar was never taken. Never.
Okay.
I mean, not never, but before diagnosis.
Yeah. Was it low at presentation? Or you don't know? It's a mystery. Okay. It's usually the really young ones. And I say under 6, I'm talking about really under 2 in particular, but it's the newborns. They could have severely low blood sugar. Okay. And I remember as a fellow, we had a baby who was 3 days old, had a seizure from low blood sugar. She had a very big cleft lip and palate, like an interruption in the skin formation. And she turned out to have congenital pituitary problems. No micro penis because she's a girl, and she's done well over the years. She's now 20 something. Okay. Now let's shift to the adrenal gland. So of course we have 2 kidneys. The name adrenal means next to. So but it's completely unrelated to your kidneys, even though they live on top of each other. So I'm assuming you're not related to your next door neighbors, but you live next to each other. So there's the right adrenal and left adrenal. Adrenal makes adrenaline, and it also makes a few other hormones. I'm not going to ask you this interactively, but I'm just going to tell you. So adrenals make hydrocortisone, the same stuff you're giving to your kids, it makes naturally. It's also, when you measure it in the blood, it's called cortisol instead of hydrocortisone, but they're exactly the same thing. Sometimes we write HC, and Cortef is one of the brands of hydrocortisone. So just give you some names. Aldosterone is a very important adrenal hormone, but it's not an issue for those with pituitary disease because the adrenal gland is fine. It's a factory, it's fine. It just needs its boss to tell it to do some things. And the pituitary only controls this part, the hydrocortisone production. It doesn't affect aldosterone. It doesn't affect adrenaline. As far as ACTH, that's the hormone. That's like the TSH to the thyroid. ACTH is to the adrenal glands. Symptoms of deficiency. So again, you get fatigue. So how do you know it's not the thyroid? Well, you don't. It's really, fatigue is a very typical symptom. You have to kind of look at, if you told me that your child's been fatigued, I would want to know if any psychologically anything big and different. And of course, there's COVID. So then you could say, well, he or she is no more depressed now than they were before COVID. So that's how we have to tease that. It could be a new divorce, could be a change. You just moved to Canada because you didn't like the politics in the United States. All those kind of things, that psychosocial. Then I'd want to know what the compliance is with the medications. I'd want to know what the free T4 level is for the thyroid. I'd want to know if the adrenal replacement was adequate. And this is a very hard thing to do. So how do we, I'm going to ask you, but not have you answer now, how do we assess the dose of hydrocortisone? So we're going to come back to that. But other symptoms of adrenal insufficiency are weight loss. So this is now the opposite of the thyroid. So here, they both have fatigue, and this one is weight loss versus weight gain. Abdominal pain and nausea. If it's more severe, low blood pressure and shock. And it can lower sodium as opposed to in DI, diabetes insipidus, I sometimes get very high sodium. So that's another clue to what's going on. Now, normally, we make a small amount of hydrocortisone during the day. It goes up and down. It's highest at, as you probably know, very early in the morning, like 7:30 to 8 in the morning. And then it starts to go down. It goes up, sometimes a little stress, sometimes goes up and down later. So measuring it is very difficult because if you told me, Dr. Alter, I don't think I can make hydrocortisone, I would say, well, why on earth would you say that? And you say, well, I'm having fatigue, I'm having some weight loss, my stomach's hurting, all those things that suggest adrenal dysfunction. Now, since you don't have a pituitary problem, I'd also want to know if you have excessive pigmentation of the skin, which is what you see in Addison's disease, but you do not see typically in pituitary problems because it comes from the very high ACTH coming out, basically. So that our kids don't get that clue. If you look on the computer, signs of adrenal insufficiency or Addison's disease, you will find dark pigmented skin, but you guys, your kids should not have that. But if you tell me that your cortisol level was certain and it was a little low, I would always say, well, what time was it done? And if you say, well, it was in the morning, it was like 10 a.m. It's not good enough. It really has to be 7:30 to 8 in the morning to check it, to make the diagnosis. We'll come back to monitoring the dose of hydrocortisone in a moment. I know I asked you that question. I'm putting that in the back burner for 1 second. So ovaries and testicles, as someone pointed out earlier, that the LH and FSH cause the ovaries and testicles to make its sex hormones. And the sex hormone in females is, do anyone know what we measure in the blood? If I'm assessing a female that's of pubertal age.
FSH?
Well, I would if this was a non-pituitary patient. If this was someone with a known pituitary tumor and they've had this for years, I'm not going to measure. I might measure that, but I'm concerned. I want to go right to the
Estradiol?
So the estrogen level, which is usually we check estradiol. So if you see in the labs estradiol, that's what we're looking at, the end product. Now for boys, it's just testosterone. So when is LH and FSH from the pituitary needed? Well, it's needed prenatally. So that's why boys are born with a small penis if they have LH and FSH deficiency in utero. It's not needed after, let's say, 1 to 10. So if you tell me I have a 5-year-old and I really want to know if he or she is going to have problems going in puberty, and then can you measure LH and FSH? It's going to be low, even if I picked the twin 5-year-old that has no, or 6-year-old that doesn't have a pituitary problem. It's going to be low. It's going to look like your normal 6-year-old who doesn't have a pituitary problem can't make LH and FSH because the brain says, I don't need this now. And that's always very interesting. That's a whole discussion. And then, of course, in puberty and adult, it's needed. Okay. Urine concentrating. So I'm going to ask you, what happens when you get dehydrated? So it was 90 degrees outside and you guys take a nice walk in the woods and you forgot your water bottle and stuff. What happens? Well, first you're going to get thirsty. So that's a brain thing. That's not necessarily the pituitary thing. It's a brain thing. If we have some kids that have problem with thirst, which means that the damage to the pituitary and hypothalamus was extensive enough that it actually affects the thirstiness. That's always a challenge for us because the body's thirst kind of always knows what to do. So what else will you do when you're walking in the woods in 90-degree weather? You'll make less urine and also be very darker. So how do the kidneys know to do that? Because the kidneys are the one that are doing that. And they have no idea. Just like the thyroid has no idea, the adrenal had no idea. It's all dependent on the pituitary telling it via vasopressin or ADH, anti-peeing hormone, antidiuretic hormone, right, to concentrate the urine. So if I gave you guys shots of if you took DDAVP right now yourselves, your urine would start to get darker and darker, and you'd make less of it. And if you drank a gallon of water right now, then your sodium will go down because your body would not be able to pee it out. So don't do that. This is how the body, one of the main mechanisms where the body keeps the salt concentration normal. If you have diabetes insipidus and you're peeing out tons and not keeping up, what will happen to your sodium? It'll go very high. It'll be like you have a cup of water here. If you have a cup of salt water and you let the water evaporate, pee off, then this will be very salty. And similarly, if there's too much DDAVP on board and you drank, it'll be like filling this up with extra water and your sodium will go down. If your child has a low sodium, I have to think about, is it too much DDAVP, too much drinking on top of the DDAVP, or is adrenal too low? If the sodium is really high, I have to think about, is this person not drinking enough, or is the DDAVP dose not enough? Okay, so now just the last section is on testing. So ADM is what we like to test for cortisol. It's good to the sex hormones like estradiol and testosterone in the morning as well. So here are pituitary labs that we typically get. We usually get the free T4. Some people get the total T4 and what's called a T3 resident uptake. And I'm not going to go so much into that, but what we really want is the part of T4 that's not stuck to proteins, because that's what the active part is. For growth hormone, we're measuring IGF-1 and something else called IGF binding protein 3. That's a little less important, the second one. IGF-1 doesn't go up and down like growth hormone does. So let's talk about growth hormone testing for the moment. I don't know how many of you had growth hormone testing, when I say you, meaning your kid, had growth hormone testing, or did they just say, well, clearly there's growth hormone deficiency because you have a pituitary tumor and some other, and like low IGF-1 or every other hormone's deficient, so why wouldn't growth hormone be deficient? Now, how many of you had gone through growth hormone testing?
We did.
Okay, so a lot of people.
We did.
Okay, so the reason for that, as I explained to families, is that like the adrenal hormone, the hydrocortisone, it goes up and down during the day. It's higher at night. So if you say to me, Dr. Alter, I think my other child has a growth hormone problem. He or she is terrible blood test. You get one shot. And I would say, okay, I'll measure growth hormone, but can I come to the house at like 1 in the morning because it's higher at night? That's why we usually give it at night, by the way, because it's naturally higher at night. And then, but really what I want to do is check 10 levels on the optimal conditions, which is what those stimulation studies are, and to see if any one of them can get up high, because it's like, if you tell me you're deficient, then they all should be low. So that's why we have those growth hormone stimulation studies. Sometimes I say to families that it's like adrenaline. If you came to me, Dr. Alter, it's nice to meet you, but I don't think I can make adrenaline. And I would say, well, why would you say that? Remember, you don't have a pituitary problem. You're just coming in off the street. And you say, well, I just think I do. And I check one level and I get it and it's low. And I go to my colleagues and said, hey, I have this mom or this dad or this child and they can't make adrenaline, the level's low. And my colleagues would say to me, so what were they doing? I said, just listening to me talk. It's no surprise it's low because it wasn't the time for it to be up. And then I come back and I say, now I have more information. I have 9 adrenaline levels. And one time where the kid is yelling at them. Number 2, they got pulled over for a speeding ticket. Number 3, they're vomiting. Number 4, someone slammed the door on their finger. Someone's honking at them in the store that they just found out their bank loan was defaulted. It's like all those scary things. And then I say that, wow, this mom, all 9 levels are low. And then my colleagues would probably say, gosh, maybe they can make adrenaline. Like you've checked it so many times. That's what we have to do for growth hormone. We have to check it so many times because it comes up and down, and it's just a hard thing to diagnose.
5-minute warning.
Yeah, good, perfect.
You do have one question from a Leslie, just to let you know.
Okay, thank you. Okay, so let me ask that question now, Leslie. All right, Amanda, do you want to ask the question, or is Leslie going to ask the question?
I can read it from her. It says, given that the body would naturally produce higher levels of cortisol in the morning, do you think it'd be beneficial to give a higher dose of hydrocortisone in the morning and a lower dose later in the day?
Yes, that's typically what we do for pituitary kids, is that it turns out you don't really need a lot of hydrocortisone on day to day. There's one endocrinologist who gave 0 hydrocortisone and only prescribed it for stress, a very famous endocrinologist from a few decades ago. And that it's the most important thing is that you give it when stressed. And stressed meaning fever, really not, child can't go to school, not so much like the test, there's a scary test. It's more of a more significant stress. But we often give hydrocortisone 2 times a day. If the kid's really obese, I bring them down to really low levels, almost 2.5 milligrams twice a day. And some people do it in the morning and in the early afternoon. Some people do it in the morning and the evening. I don't know if there's any evidence that one is better than the other. But you cannot measure the level to determine it, because right now, if I check your hydrocortisone level, I don't know what your level should be. I know it should be at 7 or 8 in the morning. I don't know it should be at 10 a.m., noon, 1 p.m., 3 p.m. I just don't know. The lab will tell me what the level is. I won't know how to interpret it. So what we usually do is see if there's any symptoms of adrenal insufficiency, like stomach aches, lethargy, weight loss, and then look at your total dose. And we know what the body's total dose, total production is, and we make sure it's within reasonable region around that normal.
Okay, we have a question from Erin. It says her child is going to be starting growth hormone next week. What do we need to do to keep monitoring growth hormone?
Okay, the most fun thing is to look at the growth chart, which you won't see in the first 2 months. But the monitoring is that most people once a year get IGF-1. They might check the glucose because growth hormone raises glucose. They may check a hemoglobin A1C. So I typically get once a year this chemistry panel, which has this and hemoglobin A1C. And
Okay,
this will go up a lot, IGF-1. Go ahead.
Okay. If thyroid hormone doses increase, should there be a corresponding increase in the hydrocortisone dose as well?
Not necessarily. That seems like someone who's very savvy, because it's true that if someone has a thyroid gland problem and adrenal gland problem, autoimmune, not pituitary, you're supposed to start the adrenal steroids first. But in the pituitary patients, we don't necessarily have to do that.
All right, Paula, do you want to ask your question? No. Okay.
My
She's-
daughter is a pediatric patient, but she's 24. I'm sure you get that all the time. But she takes 10 milligrams in the morning and 5 in the afternoon. Is that too much?
No, that's not for an adult. If someone had adrenal gland problem, they're sometime on 30 milligrams a day. That's not a lot. If she's gaining tons and tons of weight, then a consideration is to discuss with the medical team is there any benefit for giving a little bit less? But if she was feeling lethargic and tired, then they may have raised her dose. But that's a very classic dose.
All right. Thank you, everybody. You should get ready to move into your next session.
I'll see you at the question and answers at 2:45 p.m. Eastern Time.
Thank
Bye-bye.
you.
Bye-bye.
Thank you so much.